Um, Hello, good afternoon, everyone. Myself, Dr. Megha Patel, and my topic is posterior uveitis for today. So, going ahead, basically, what is posterior uveitis? Posterior uveitis refers to inflammation primarily involving the choroid, and it can also extend into the overlying retina and the vitreous gel that fills the eye. Posterior uveitis is basically divided into two parts, that is choroiditis and retinitis. Today I am limiting myself to choroiditis because in itself the choroiditis is a huge topic. Would require some other class also to go ahead with retinitis. So choroiditis is further divided into choroiditis basics, choroidal granuloma, that is sarcoidosis and tuberculosis, serpiginous-like choroiditis, and Mimickers, all layers of the choroid. So by clinical method, we cannot point out whether it is a deep seated or a superficial seated or covering the full thickness. So in order to know, we have to go ahead for some angiographies like fluorescence fundus angiography or ICG, or if these two are also not available, then we can go ahead with a normal OCT. So optical coherence tomography also helps us to know whether it is a superficial or a deep choroidal lesion. Then going ahead, third point, there are certain patterns which helps us to know whether it is a primary choroiditis or a secondary choroidal involvement. If it is a primary choroiditis, then it can be like patterns like choroiditis like choroiditis, serpiginous-like choroiditis, infections like syphilis, and
blurred vision with floaters. Think beyond anterior causes. This could be posterior uveitis. Posterior uveitis involves inflammation of the retina and choroid, often sight-threatening. Key symptoms: floaters, decreased vision, photopsia, and sometimes minimal pain. Causes may be infectious, like toxoplasmosis TB, or non-infectious autoimmune conditions. Fundus exam reveals vitritis, chorioretinal lesions, and vasculitis. Investigations include OCT, fluorescein angiography, and systemic workup. Management depends on cause: steroids for inflammation, antimicrobials if infectious. Delay can lead to complications like macular edema and permanent vision loss. Early diagnosis is key. Manage aggressively to preserve vision.
Okay, coming to tuberculoma, which is due to Mycobacterium tuberculosis, most likely atypical Mycobacterium. In this, you can see the fundus photograph, which is showing a dull yellow lesion, single monoloculated. It is a solitary, always a solitary. It's always very large. Large can involve the disc, can be involving without the disc. It can be anywhere in the eye. If it is below the disc will be appear lifted. And it is having most common location is perivascular, but it can be below the disc also. Always it is a full thickness. All the layers of the choroids are involved, intense yellow and lobulated. So these are the very characteristic features of tuberculoma. Associations: there is a dilated tortuous overlying vessels, exudative retinal detachments, hemorrhages, retinal angiomatous polyp, that can be CNVM associated with type 3 CNVM associated with the tuberculoma. Old chorioretinal scar can be seen. So what are the clinical difference of a granuloma between a tuberculous granuloma and a sarcoid granuloma? So the first image is of a sarcoid and the other images are having a tubercular granuloma. So we can clearly see that the photograph, which is the list in which you can't know the extent, can't know the activeness of the major, or the first is ICG. Then there is an FFA. And
is it a tumor or something else? Tuberculoma is a focal granulomatous lesion caused by Mycobacterium tuberculosis. Commonly seen in the brain, especially in endemic regions. Presence with seizures, headache, or focal neurological deficits. MRI shows ring-enhancing lesions, often confused with tumors or abscess. Histology reveals caseating granulomas, key to diagnosis. Treatment: standard anti-tubercular therapy with steroids if needed. Recognize early, treat effectively. Think tuberculoma.